Very good afternoon, one and all. I'm Dr. Deepa Bhat. I'm a senior genetic counselor and professor and head of anatomy at JSS Medical College, Mysuru, Karnataka. And also, I'm a coordinator for Mysore Rare Disease Care Coordination Center for Organization for Rare Disease India. It gives me immense pleasure to introduce the esteemed expert for today's session, Dr. Saurabh Dani, who is a renowned obstetrician and gynecologist at GEM Nama Cloud9 HCG Mumbai, with his special interest on high-risk pregnancy and newborn screening. He is a general secretary of Kandivali Medical Association, past president and advisor for Association of Fellow Gynecologists, Mumbai, Indian Society for Prenatal Diagnosis and Therapy, and coordinator for MCGM newborn screening program. So today we have him with us to share his experience and also contribute towards the topic which is very close to my heart, that is, are we ready for rare disease in India, the missing link? So without wasting much time, over to you, sir. I heartily welcome you for the session on behalf of ORDI and all the participants. Over to you.
Thank you, Dr. Deepa, for the wonderful words and a kind introduction. So, let me straight away dive into my topic for the day. So, as you can see the slides, I hope everybody is being able to see the slides. So, today is the 52nd session, if I am not wrong. That's the number which I've been given. So, we already have a lot of talks happening on rare diseases before I have come and given a talk today. So, when I was asked this question that what are you going to talk on? So I was really trying to understand what should I talk. I went through a lot of different sessions which have been already covered, and I found that yes, we are talking a lot of rare disease, but we are missing out on something. And so I've given the title of my talk as "Are we ready for rare disease in India? The missing link." And as you realize, if you see the image, newborns, rare disease is like a relay race, the baton has to pass from one person to another. And if it does not pass from one person to another properly, yes, we lose the race. So moving back, and this is exactly what I think Dr. Deepa introduced me. And the reason why I'm putting this slide here is because why should you really listen to me? Okay. Because I have been doing and practicing newborn screening from a decade now, and I have been advocating it in Mumbai. When the Mumbai newborn screening program was ongoing, I was part of the team coordinating it, and we have collected a lot of data, which is very insightful. So, moving with that, I'm sure you must have seen this in papers recently. This was all over the news, on all the TV channels. It was there on all the print media, everywhere, even on email, WhatsApp, and everything. This is a very familiar situation which has just happened recently in on the expressway between Mumbai and Pune. And there was this traffic jam, which was for hours and hours of traffic jam and kilometers of traffic jam. And it's not that only Mumbai has witnessed this or Mumbai and Pune have witnessed it. There are a lot of cities in India which could have witnessed this. And what had actually happened? One critical link which is connecting the Mumbai and Pune expressway, one tunnel where there was a gas and a tanker which is overturned and it was leaking harmful, dangerous gases, and hence they had to shut down the whole expressway, which was leading to the traffic jam. So this was always thought of. Everybody always knew that there is a problem, and that is why there is a missing link which is being made between Mumbai and Pune, which is an alternate to this solution. So that if tomorrow again such a thing happens, then the same problem of traffic jam for kilometers doesn't happen, and that's the solution. And if you really realize, it's the systems fail not because it does not exist; it's because the critical links are missing. Okay. So now coming back to our topic, if you talk about what India is talking about in rare disease, India is talking about rare diseases treatments. India is talking about rare disease gene therapy. India is talking about the financial assistance for rare diseases. India is talking about patient registries for rare diseases. And India is talking about the center of excellence for rare diseases. But we are still not asking one question. Are we really still ready for rare disease in India? Okay. So over next few slides, let's discuss this part. Are we really ready? See, if you look at globally, what is really happening, there are more than 7,000 known rare diseases. Okay. Almost more than 70 to 80% of them are genetic in nature. The origins are very genetic, so they are parental. A lot of them are present in early childhood, and early diagnosis can definitely change the outcome of the babies who are suffering from this rare disease. Okay. So this is the very global and which is a very acceptable fact. So no one disputes this part of the rare disease context. So if you really look at what is the national policy for rare disease in India, it has three main focus areas: the financial assistance, the center of excellence, and the treatment support. But we are only talking about 63 rare diseases out of the 7,000 plus rare diseases which are known to us. Okay. So what is the real challenge today? The real challenge to us is the diagnosis. There is years of delay. A lot of times the parents need to have multiple consultations with different types of doctors, and all this leads to irreversible complications. So the challenge which each and every parent today faces in India is this. And this is what we need to address. So let me give you a very simple example. This is what I have witnessed. So Mr. H, uh, obviously I'm hiding the names for anonymity. Okay. He is born in 2001. Okay. And the report is confirming the disease in 2024. So this person, so it's not even a child anymore. Okay, this person is detected at the age of 23 years to have a PKU. It should not take 23 years. Okay, so this is the kind of situation that we are looking in India. Okay, but I don't want to paint a very grim picture of this as well. And there is this other case, this baby which is born on 25th of April 2024, and by 8th May, that is just within 13 to almost 15-20 days, has been detected to have IVA or short chain acetyl coenzyme deficiency. So definitely it's not that we cannot diagnose it early. Okay. But we should have the intention of looking forward for that. So by the way, this patient was from the earlier patient was from Pune. So because we were just talking about Mumbai, Pune, so I just thought let me just throw that. So what is the diagnostic odyssey? What the families really face when they are looking out for a disease? It takes as much as 5 to 10 years just to reach a diagnosis. They would be jumping from one doctor to another, one hospital to another, one consultant to another, one specialist to another specialist. A lot of times in the process of reaching a diagnosis, a lot of incorrect and inadequate treatments are also given out. And this is what we call as the diagnostic odyssey. But the fact is that some of the diseases are definitely detected at birth. Okay, so what are those which can be detected at birth? The metabolic disorders, the endocrinological disorders, and some genetic conditions as well. Many rare conditions can be detected immediately or very soon after the birth, and much before the symptoms appear. And what is the solution? And what is the world found a solution for this? That is called universal newborn screening. So the global solution for this problem and to address this issue of early detection is newborn screening. Okay. So today we have to move away from this word newborn screening and move to this word of universal newborn screening, which is very important. Okay. So what is universal newborn screening? Generally, there are multiple parts to it, but since we are talking about genetic disorders, we'll only talk about the blood type. Okay. So it's a simple blood test which is done after 24 hours of birth and within the first 72 hours of birth. This is the ideal time to do this so that we can detect these problems early. And by doing this, what are we achieving? Okay. We achieve early diagnosis. We achieve early treatment. We help in prevention of disability and even prevention of eventuality or death. So that is why newborn screening plays a very, very, very significant role. Now, what do you see? What do you think the world has moved on to? Okay. So if you see the world, all the blue shaded areas, so these are these areas, this blue, this blue, this blue. These are the places where newborn screening is as a public health program very well universally accepted, doing and almost doing 100% of screening of the babies. On the other hand, if you look at India, which is green, which only means that there are pilot studies and low national coverage and limited availability. So this is how where we are placed today. So universal screening exists in USA, in Europe, in Japan, in Australia, and many, many, many middle income countries. So we are priding ourselves to become the third largest economy with respect to GDP. But are we even comparable to southern sub-Saharan region? So we are almost of the same. They are also green, we are also green. And that's purely because universal newborn screening penetration is very poor in our country. So something we need to really look at and focus on. So what is the India's current reality? Okay, first is we don't have any nationwide mandate. Okay, so there are some isolated programs going on. There is some limited private sector involvement in this, and there are some state pilot projects which are on. That's the extent of newborn screening that we are seeing in India currently. So I was part of this Mumbai newborn screening program, as I just told earlier, between 2019 to 2022. That was a 2 or 2.5 period. That was also the part of the COVID period. We were doing newborn screening in the four medical colleges in Mumbai, and we are screening for thyroid, G6PD, congenital adrenal hyperplasia, and hemoglobinopathies. Then Goa is now moved on to phase three of its newborn screening program. There are some districts, states, cities who are attempting to do it. But basically, if you see, it is inconsistent, it's incomplete, and it's inadequate. We do not have a lot of even data emerging out of all the projects which are, or all the newborn screening public health programs which are happening in the country. So if you, so this is one question which I had heard from one of my colleagues, my gynecologist friend. So I was just talking about him when I met him at a conference, and I was talking to him, and I asked him, "Okay, do you do newborn screening?" He said, Saurabh, why should I be doing it? I don't see any guideline from the state government saying that it is mandatory. I don't see any central government guideline saying it is mandatory. Then why am I supposed to do it? It doesn't make any sense. Till the time there is no mandate, means there is a reason. Yes, and that's what I also felt. Yes, we are what we are lacking is a mandate. Because without a mandate, it becomes very difficult for a doctor or a clinician to convince the parent that yes, this is very important and this should be done. So now let us come back to the India's rare disease ecosystem. So if you look at India's rare disease ecosystem, uh, what we have is centers of excellence. We have advanced diagnostics. We have a lot of labs who can do all the advanced diagnostics. We have patient registries which are being started. We have some form of financial assistance which is given, and we have gene therapy discussions also. So India is building all of this, but something critical is still missing. So what do you think is the missing link? Okay. So before we talk about the treatment, before we talk about funding, before we talk about any advanced therapies, we need to answer one basic question. What are we missing? Or are we really missing it? Or we have even understood that are we missing something? Because like if you look at the Mumbai-Pune highway, if you would never thought about the missing link earlier, we would always thought that yes, this is a good, there is nothing that needs to be done. Okay. So if you look at the missing link, we cannot treat what we cannot find. Okay. The first step to any rare disease ecosystem is early detection. Because if you cannot detect early, we are just going to increase the morbidity. So just like the expressway bottleneck, Just like the Mumbai-Pune Express needed a missing link to function effectively, India's rare disease ecosystem also needs its own missing link. And the rare disease missing link in India is universal newborn screening. Without an existing mandate on universal newborn screening, we will never be able to achieve the target of detecting more and more babies of rare disease in India. And we will always detect them, but at a very, very late age and at a very high cost. So India has expertise. Okay, India has laboratories for newborn screening. India has the health infrastructure to diagnose rare diseases, but India does not have a mandate. We have everything that is required, but no mandate. And what I request ORDI and all other people, whether in the clinical field or the non-clinical field, in the administration, in the bureaucracy, is to come out with a mandate. Without a mandate, it becomes very difficult to implement universal newborn screening. We have a national policy for rare disease 2021, but we also need a national policy for newborn screening. Basically, NBS is nothing but it's a test which is done once in a lifetime, and hence quality becomes very important. What we need is robust quality controls, time-tested standards, and results we can trust. NBS is just done once in a lifetime, and we owe it to the baby, to the parents, to the family, to the society to get it right every time. We cannot have mediocre results as far as newborn screening is concerned. This is not a simple test. This is a very specific test for a very specific person. A wrong results will either create a lot of apprehension in the parents or we will miss out those babies. And we can't afford to do either of them. So when we talk about robust quality control, what are we really talking about? Is a good NSQAP, okay, quality control program, a proficiency testing, NABL, and standards as per the CLSI guidelines. We have time-tested standards. You use reagents which are good quality reagents, well-tested, endured. Time-tested technologies, no new technology which have never been time-tested. Quality filter papers, Lancets, and following all the international guidelines. And results, when we say results that we trust, the results should have low false positives. I know we cannot avoid false positives. We can definitely, but we need to have very low false positives. Absolutely no or very low false negative results. Focus on quality and qualified experts. We have qualified experts, but we need to see that every result is being checked by a qualified person. So, not related to what I'm talking today, but if you just see this, this was an article which was published where CAG was auditing FSSAI over the process of find fire food testing labs. And what it found out is that the CAG, FSSAI, when they are sending the samples for testing, out of the 72 labs where they sent the samples, 65 did not even have NABL. Okay. And other labs which had NABL, some were being tested by technicians and by people who did not have the expertise in testing for food quality standards. So this is what we mean. So if a government agency is not being able to find labs which are the best for what they want to test for, just imagine what a private sector must be facing. We always debate about the quality versus cost. And my personal opinion is very simple. We are doing a test which is once in lifetime. We owe it to the parents, we owe it to the child, and we need to choose a lab which has focus on quality because cost is not a big criteria. It's hardly a few hundreds of thousands rupees here and there. But if you make a wrong judgment, you are just going to penalize the family and the child for a very, very long time. So definitely quality has the most important criteria as far as my practice is concerned. So with this, I end my talk. Uh, It was a short talk. The whole focus was on what are we doing today as far as rare disease is concerned and what are we missing. And I'm open to any question and answer that you may want to put across my way.
Right. Thank you, sir, for giving a real life setting. And also, the analogy which you gave was fantastic, and the link. So, first, I have plenty of questions um, because I work with the government. So, I know the challenges. So, I have few things to ask you. Before that, I request the participants to leave your questions in QA if there are any. Otherwise, I'll start with my queries. So till we see some of the questions, so the link. Who will bring this link between obstetricians and pediatricians is my first question. Who will bring the link between public and private? Because my institution has a very well established both basic and the extended newborn screening. We follow the protocol as per the AIMS protocol that's available. When I approached the government saying that we have all the setup, let us have a public private partnership, so that was not supported. Still I'm struggling, especially my area of expertise is I'm working on hemoglobinopathies. So we have all the setup for that. So Ministry of Tribal Affairs gave a 4.5 crore instrument to the neighboring, in same place we have a government medical college, all top-notch Sanger sequencing, isoelectric focusing, everything came, but there is no person who knows how to use. There is no manpower for the basic extensive load handled by the hospital. So how to, uh, according to your experience, how this link can be brought? And also, because the obstetricians spend 9 months with the families who could be having a prior child who has been lost at 5 months, because most of the peripheral setup, what happens is at 5 months baby is admitted. By the time it gets diagnosed, probably because of organic aciduria or something, it would have been lost. How this link can be established from the obstetrician to a pediatrician or a neonatologist?
So, yeah, thank you. I think you have raised two questions which are separate. One is about the relationship between an obstetrician and pediatrician related to newborn screening, and second is how to go about a public health program as far as newborn screening is concerned, utilizing the resources which are available in the public sector as well as the expertise which is available in the private sector. So let me address the first part about the obstetrician and the gynecologists and the pediatricians. See, I definitely agree that it is the obstetricians who need to take a lead as far as newborn screening is concerned. And one of the logical reasons which I put forward is that, which you also mentioned, is that the obstetricians, so people like us, we have already been in the relationship with the parents. As far as the newborn, because the newborn is not going to say anything themselves, it is the only parents who are going to make those decisions. And that is why the confidence of the parent is most important. And one person with whom they have a lot of confidence is the obstetrician, because they have been going on through the pregnancy journey with them for such a long time. Saying that, so that means that as in the West, what is being done is that there is information about newborn screening which is shared with the parents in the antenatal period, telling them that something like this will happen after the baby is born, so that the parents have made informed choices. So even if they don't want to do something, they are not impulsively saying no, but they are informed, they know about it, that we don't want to do it for whatever XYZ reason, and that is why they are saying no. But not just because you thrust that question last moment and because they don't know what to do, they are just saying no. So the whole idea is making informed choices. And in my experience, what I've seen is that as as more and more information is made available in different formats, it's not necessary that you need to counsel each and every parent one on one, but general counseling or general information definitely starts making them more prepared about it. And then after delivery, that one question by a pediatrician saying that I know that you must have been told about newborn screening earlier, So we will be doing that test, and maybe today or tomorrow or day after or something like that. So this is how together, synergistically, the pediatrician and the gynecologist together can increase the penetration in a local setup. Okay. So this is more applicable in a private setup where parents are paying for the test and they need to choose an option. But in a public setup where everything is given for free, there probably a mandate is more important. So what happens if today I don't see any government in any part of India which has come out with a mandate saying that newborn screening is a recommended test and it should be done. There are, even if you look at RBSK guidelines or you look at other stuff which is available, even if you look at the red, there is a small paragraph of mention of newborn screening saying that it is important. But nowhere it is mentioned that yes, attempts should be made by the government or the state or the center to see that it goes on. We have different programs. We have a tuberculosis program, we have the leprosy program, we have the sickle cell anemia eradication program. We have so many different national programs, but we don't have any program which is specifically catered towards newborn screening. And I think here is where the civil society, that is the NGO like ORDI and Mud India and other organizations, will have to really push forward the government into coming out with some kind of guidelines. As professional bodies, IAP, NNF, or even Foxy, they all have recommended, but the strength of that recommendation is only as far as the clinician believes them to do. But as soon as you have a mandate coming from the government or a high, strong recommendation coming, then what happens is this body's recommendation adds teeth to it. And that is why it is very important for the government to come out with such mandates. So now I'll address the second part of your question, which was about how do we tackle the public-private partnership model. Uh, See, a lot of times we believe that just installing an equipment is adequate enough to run a test. But you have to realize that newborn screening is never called as a test. It is always called as a program because it just does not involve one part of getting the sample, running it in a lab, and giving a result. If you look at newborn screening, it starts from a very early phase, that is education, followed by sample collection. Then you have to do sample testing. After sample testing, then is the lab reporting. After lab reporting, then comes post-test counseling. And if it is positive, then confirmation, and after confirmation, treatment. So it's like a pulse polio program. Okay. We never say it's a pulse polio day or a pulse polio vaccination drive. No, it's a pulse polio program. Similarly, this is also called as newborn screening program. So the lab testing is just a small fraction of the whole program where just the results are generated. But there is a lot of other work which needs to be done before the lab test and after the lab test. Till the time we don't address the whole program as a whole 360-degree thing, we are never going to have a successful program. So briefly, I can only talk about what I have been involved with. So in Mumbai, when we were doing it, it was a public-private partnership. So it was with a lab based in Bangalore. And what we did is that right from the initial parts, from consent, the lab processing, the collection, the lab processing, the reporting, the follow-up of all the false positive or the false negative reports, and confirmation test was all handled by the private lab. So because of which what happened is there was a complete, I would say, liability of the private partner to see that they completely do everything properly. Now, what happens in a lot of other locations when the government is doing themselves, they are only doing one part of the project. That is, maybe the samples are sent, labs are processed, but now even the lab doesn't know what has happened after that. And that is another problem of the whole chain of the program because you should never be able to just know that okay, it's screening test positive till the time you don't do a confirmatory test and actually confirm that it is a real positive child. It, you will never get to know what is really happening. And which was one beautiful part of the whole Mumbai program was that every baby which was screen positive was actually tested as a confirmatory test. And our data actually had this confirmatory positive data, not only screen positive data, which I have not seen in any other program across India. And if it is existing, the data is not available. Yes, we have lack of resources. But more than lack of resources, I think we have lack of conviction. And because people have not understood what newborn screening and what it really lays the foundation for a future healthier generation, that is why it is not being promoted the way it should have been. But as you said, even if you start with something very small like thyroid and sickle cell, I think the most common problems in India that we see is thyroid, G6PD, and hemoglobinopathies. So even if we just start as a very basic thing, which is just with these three or four disorders, I think it's good to start with something very, very, very small. And then once you build a proper base of and cover a good population of your zone or district or area or city or whatever part you want to do, your target population, then you should increase the number of disorders. Unfortunately, we are going into this rat race of the numbers rather than the quality. We are focusing more on doing more number of disorders rather than screening more number of babies. And that's the problem which I have seen in public health programs.
Yes, sir. Thank you for your answer. We have in chat box. The first question I think you have already addressed that why Foxy and NNF not give the guidelines. So you have indicated that. The next question is why gynecologists not focused to inform NBS, but they scan 6 scan and 3 marker for unborn child. So that's the first question.
Uh, get this. Why are they what?
Why gynecologists not focused to inform about NBS? It's general. Like why are
Yeah,
they not?
it means it's not if they're not. I think it's that overall lack of awareness. The way we think that the public is there is a lack of awareness in the general population. There is even lack of awareness even the clinical doctors population as well. I think even pediatricians to that extent they are aware of it, but it's still not made because there is no mandate, and it's not mandatory for them even to recommend it because there is nobody who tells them that you have to. So the only way this can move ahead is only one way. Either the government comes with a guideline or some consumer court is going to penalize somebody for not doing it.
Fine, sir. What is the rough date of Mumbai program of the 4 diseases?
Okay, so we did almost around 35,000 to 40,000 babies, which we screened in that period. And for thyroid, the incidence was 1 in 2,000, 1 in 1,800 or something like that. G6PD was 1 in 200, 1 in 200, 1 in 250. CAH was almost 1 in 5,000, 6,000. And hemoglobinopathies, which does not include a thal trait minor, we cannot do that screening at birth. So besides that, all other hemoglobinopathies, which is hemoglobin C, D, E, sickle cell, and thal major also. So that came to be collective incidence is almost 1 in 75. So that's the kind of data that we got it from Mumbai.
So how many countries doing universal newborn screening globally?
Oh my God. I think most of North America, most of Europe, uh, even in the APAC region, even the Middle East, a lot of countries are doing, most of the countries are doing it. Then you see Japan, in Southeast Asia, you will see Asian countries are actively doing it. So I think there are only few countries. Russia is doing it, China is doing it. So I think only handful of countries are not doing it. It's probably just easier to name the countries which are not doing it. So I remember several years ago, even Pakistan had started a program. Now, current it's not going on right now, but Sindh province in Pakistan also started a newborn screening program. But currently, it's not doing. So I would say probably the Indian subcontinent is not doing it, which would include India, Nepal, Bangladesh, China, Sri Lanka, and Nepal. Then you will see sub-Saharan African countries not doing it. Uh, Otherwise, most of the other countries around us are doing it actually.
Yeah, the one more last in the chat box is please describe RUSP
Okay, so RUSP is an abbreviation for Recommended Universal Screening Panel.
screening.
Okay, so how this works is that when I said that we have around 7,000 different disorders, genetic disorders. So why don't the question comes is why don't we screen all 7,000 of them? Okay. So we objectively try to put all those questions in a matrix wherein we ask one standard question as per the visitors and Jagner's criteria that whether these disorders should be included as a part of the screening panel or not. So those disorders which have a treatment where an early diagnosis is possible, where the cost of treatment is not exorbitant or not, and where early treatment changes the way the outcome of the child is. So based on these questions and answers, it is decided whether that disorder should be included as a part of the screening panel or not. So if the answer to that is yes, then it is included in the part of the screening panel, and then it is published under by the I think U.S. Department of Health, where they are publishing this recommended universal screening panel. So it's a very dynamic panel where you will see what disorder is not there today will probably come up after 6 months or a year or so. So as more and more studies, more and more of data is available, and more therapies are available, they will add more and more disorders into the list. So that is your recommended universal screening panel. And this also answers one more ethical question that because again, Indians love numbers. So a lot of times you see that why don't we do 100 disorders? Some tests can do 100 disorders. But you have to realize that what we are is into is a screening test. We are not into the diagnostic RAM. So because we are in the screening test, we need to focus on what should we screen, not what we can screen. Okay. And that is why we restrict ourselves ethically only to those disorders which are part of the RUSP. So if you ever want to start a screening panel or a screening disorder for any child, you should see to it that you're not doing more than beyond the RUSP. Because if you are doing anything outside the RUSP, it is ethically challenging for a person also. Unless until the baby is sick and you are looking at it not as a screening but as a diagnostic tool, yes, it's a different story. But for an asymptomatic child at birth, when you're doing a screening test, you should not go beyond the RUSP.
Yes, sir. Thank you. And the last question from me only. So it's a double-edged sword because many times we do the screening and the reports are sent to parents. It is positive, which they are unable to interpret, and it creates a lot of panic because they wouldn't have been undergone any pre-test counseling, and even screening has to be repeated again to have a positive before going to confirmatory testing. So somebody has to explain. So if it's not as simple as just bringing a mandate, so how can we what is a way forward to address this?
Okay. So this is how we address this issue. Any abnormal or screen positive report was never sent to a parent. Okay. That report used to come to our team, and our team used to call the parent, talk to them, explain them, and not reveal the results, but tell them that there is something which is not right in the report, and we need to have a relook at the child. Why don't you bring the child back, and we will do a retest on it. Okay. Because the fact is that any newborn screening program inherently is focused towards very low or no false negatives. And to achieve that, you will always have some false positives. Okay. So that is a trade-off which always happens. And for this trade-off, that is why we will get some babies whose report will be false positive, but maybe on a subsequent repeat test, they will turn out to be normal. And this is the inherited design of a newborn screening program. Okay. And so not giving the results to the parent, I think is the first thing as far as the abnormal result is concerned. Calling them back to the place where the testing was done, unless and until you have a parent who has moved or migrated out of your zone and is not going to come back and they are probably going to go to somebody else, then maybe you may be able to share those reports. Like I remember one case where we had congenital hypothyroidism, TSH levels were very high, but when we called the parent, they told us that the mother has gone to Lucknow. She delivered in Mumbai, but she went back to Lucknow, and now she's not going to come back for another 3 months or 6 months or something. Now that becomes a critical challenge for us because we need to start the treatment. If the baby is congenital hypothyroid, the treatment needs to start within the first 2 to 3 weeks of life. So that is the time when we explain the parent. Again, the number which we had was of the husband who was in Bombay, but the mother was in Lucknow. So then we got the number from her. We counseled her on phone, explained her what exactly is, told her to get a local test done there and share us the report. And once she shared the report with us and we confirmed that it was positive, then we told her what is the next steps to be done. So yes, post-case counseling is very, very important, especially when you get a positive result. And this is a very important part, which a lot of times is missed out because what happens is the labs are just interested in giving you the result and less everything you have to do. So again, coming back, it's not a test, it's a program.
Yes, sir. And the last, how to choose a lab.
Okay, so one of my, I just shared in my slides the different quality parameters that you should be looking at. Okay, the way I look at it is I don't look at the cost. Okay, because today the amount of money, insane amount of money that we spend behind a child, compared to that, the amount of money that you are going to spend for a test is minuscule. Okay, even if you look at a simple phone, there is no phone in the market which is available. Cheapest is 15,000. Nothing is cheaper than that. And that the life of that phone is 1.5 to 2 years max to max. The amount of money you are going to spend behind the clothes of a child, the school, the education, and everything, it's too much. So if you look at all that, maybe 5,000 or 6,000 or 7,000, or whatever panel you are thinking of, it's hardly anything because that cost is divided over a lifetime. It's not just for that 1 day test. Okay, so it hardly comes to any amount. So I just don't look at the price. Now I have to look at the quality. So when I'm looking at the quality, what is the first thing? Are they NABL? Do you have NSQAP? So NSQAP is normally done with CDC Atlanta. So that, not just that, that just doesn't give you the complete picture whether they are good or not. So what you have to ask them is the proficiency test results. So there is this data which the the CDC gives the labs for them to improve in cases if they are not as per their benchmarks. And those proficiency test results, if they have improved or become better over a period of time, that tells you this how good or bad the lab is. Because at the end of the day, it's how much the lab is really interested on giving quality results. That's important. You could just process a sample and then who are the people who are managing the lab? Do they have any formal training or education as far as running these machines? Because today, even if I look at Bombay, even in places around a medical college or something, you'll see so many small labs mushrooming. All they do is get some equipment, some auto analyzers or something, and there's some BSc, DMLT technicians who are running the lab, and they just give out the reports, and then you are expected to do everything about it. So what is the kind of backup that these labs are providing? So all those things are very important, and everything that I'm saying adds a cost to everything. Okay, even the filter papers, you will see so many times so many filter papers. I have seen filter papers where people have made circles using pencils, somebody has put gum on it, somebody is putting some tapes on it, to mark circles. We don't realize the small issues, but they all interfere with the kind of results that happen. Because the even if the filter paper, it's not a regular filter paper or blotting paper you can get from a stationery shop. The amount of ash content which is there in it, how much will adsorption is there, what is the amount of volume it is going to absorb of blood it is going to absorb, all these parameters. So if you don't have a good quality filter paper which can be backed up by a company, you are really not going to know. See, one good thing which I've seen is that most of the public health programs which are happening, they end up using good products. Okay. So they will have reagents which are CE marked or FD approved. They will use good filter papers, they will have all these things. It's the places where in private sector you see that all these corners are being cut.
Yes, sir. Thank you for such an elaborate. We had quite a number of questions answered by you. So, any more questions from the audience?
So I believe I have a question for you. I believe you are from Mysore, right?
Yes, sir.
Okay. So and Mysore, you are planning it. And what is your experience? Why you think that it is not working at a local level?
Sir, I have been from past 8 years working with sickle cell disease.
Correct.
So I feel that once it comes, somebody politicians should suffer, then it will become a mandate. So if it becomes a mandate, it came as a national mission. It was fantastic. Wow, because we at within 1 year we could have so many number of sickle positive. We started on hydroxyurea, that was very good, all were in place. But unprepared, the government had to show the numbers. It's not the quality. So there was always a compromise between the quality and So locally, I feel the interest definitely has to come. Second thing is, I always feel it has to come from the government. So if it comes from the government as a program, then at least I wouldn't expect it to be a perfect running over a period of time. Now, TB program has evolved like anything. It's very well monitored. So it will take years to come. So NPRD was announced in 17, 2021 it was modified. But how many the Nidan Kendra is at placed in some place. I can't. Mysore to Bangalore is 140 kilometers. I'm not able to send my patient till 140. The Bidar, which is, or the middle, if I take, they're not, the geographically, socio-culturally, economically also, they're not able to. Uh, I feel the awareness at the medical fraternity itself is very low. Second is acceptance is very low. Why should I? So, and they don't think with like family history, past history, nothing is. If a child comes now, only that child is focused. So there is no one step going ahead asking earlier histories. So that is where things are. Every pregnancy, every child is treated as an individual. So I think the different medical levels like pediatric, neonatology, or obstetrician, anywhere, some section has to be there to bring these components so that even either through the health and family welfare or RBSK, if you look at that guideline, it's so beautiful, but how, is it practiced? To what extent it is making a difference? It's done at a A&M level. Are they really able to understand it? Folic acid we are giving after 3 months, but what is the purpose of post 3 months folic acid? So still we are getting a lot of NTDs. I think we have still a long way to go. Mine, wherever I'm speaking, or I feel it has to be from the government. Once the engine is in place, the bogies by default will start coming behind.
Yeah. So that's very interesting what you said is that the government should take an initiative. But I will give a counter argument to this in a very different way. Like if you see government gives vaccinations in public hospitals for free, but then there are other pediatricians who also give vaccinations in private at a fee, right? And both work together. Like for example, government will have its own program where it will let's look at a recent example which is just started. The government has just started vaccinating girls at 14 years of age for a 90-day program for HPV, right? Now, if you look at the manufacturer guidelines or most of the Foxy guidelines or even the IIP guidelines, they always recommend that 2 doses of vaccine should be given. Okay, or three if their children are older in age. So 9 to 14, it's 2 doses, and 14 and above, it is 3 doses. But uh, it's not that government is doing something wrong. It's a good thing that they are doing it, but they are doing it at their level and at whatever revenue or funds they have. But then there is a big chunk in India, or which goes to the private sector also. Now, the people going in the private sector do not need any approval from the government for doing or not doing something, right? So nobody stops this segment of private practitioners from starting a newborn screening program in their own setup for their own set of tools or patients. So for which you don't require any government mandate. It's just that they need to get convinced that this is very important and this is what I need to do for my patients. The way I would say is like when you're doing a delivery or a C-section. Okay, we all get a HIV done or any surgery for that matter. Okay, you get HIV, HBsAg, anti-HCV, all this triple H. This is what we call it. We are not asking or seeking permission from neither the government or the patient that we should be doing. We say, okay, no, this is in the interest of the hospital and this has to be done. Similarly, we as a healthcare setup need to decide, say, okay, this is my jurisdiction. My jurisdiction is my hospital, or my jurisdiction is my patients who come into or walk into my OPD, and I will be doing newborn screening for each of everybody of them, and that's it. So those mandates are nice to listen to as far as the public is concerned for a public health program, but nothing stops the private practitioners from starting this in their own jurisdiction. And I think as a group, we have collectively failed to emphasize or impress upon the clinicians that in your jurisdiction is something which is in your control and you should be doing it.
Yeah,
That's it.
I agree to that definitely, sir. But my version, because if we take an entire state, the percentage of people who can afford to go to a private practitioner percentage wise so would be less. But definitely the flexibility should be there for a person to opt. Either government should take an initiative to spread an awareness, because that should be, but the choice to go where they would go, there should not be a complete restriction on you should get here only. That I would definitely agree. But considering the major chunk in the rural or semi-urban population, not everybody has a privilege to have the expertise who understands all these things.
No, no,
So
I
that is
absolutely
my,
agree. I absolutely agree with what you're saying. But if you look at historically what has happened, maybe not only in India, but across the world, it's always the private sector which initiates something, which takes it on, and then it goes on to a tipping point, after which then the public sector starts doing it. Forget even HPV. HPV has been launched in India maybe how many years back? 10, 15 years back, the vaccine. Okay.
yes.
And it took 15 years for the government to make one single dose mandatory. Okay. So what I would say is that once your private sector starts moving forward, you will automatically see the government sector falling in its place. Unfortunately, what is happening is that there is an excuse by the people who don't want to do it, saying that the public healthcare system or the government has not come out with any mandate. But at an individual level, if you just start implementing it, I think it will bring a lot of change. Forget change for the country, but at least for your patient pool, it is going to make a big change.
Yes, definitely. It's mandate in our hospital, the basic screening for all the
Absolutely. Yes,
involved.
yes.
So,
Absolutely. It should be done. Yes, yes, yes. Absolutely.
and NICU has a different protocol for the sick
Fair
newborn, which
enough.
has
Yes, fair. Because data has always proved that, the babies who are in NICU are at least 2x or 3x likelihood of suffering more genetic problems compared to those who are non-NICU admissions. So definitely makes sense to have that different protocols.
yes, sir. Chetna,
Yes, ma'am.
uh, shall we
I
wind
think
up?
we reached the end of the session. Thank you so much.
Okay. Thank you, sir. We
Thank
had a
you.
lot of insights. Your words of wisdom itself speaks vast experience you had, either from the private or whether it's a government, but it's finally the outcome.
Yes.
And it's a collective effort, and also the responsibility from each of the clinician, which is in future going to make a difference for the its parents or the patients. So thank you for your valuable time. Thank you for giving us wonderful information and being with us. And my wholehearted thanks on behalf of ORDI family for this event. Thank you so much.
So thank you, Dr. Deepa ORDI, for asking me to come over today and sparing. I'm sure this 1 hour, if it just influences just even one doctor to start newborn screening, I think my impact has been made. But I would also urge ORDI and other organizations like that to see to it that we come out and focus towards getting some mandate, either at state level. We have to realize that India is where health is a state subject, it's not a central subject. So every state will have to come out with its own version of mandate. So let's work together, try to come out with some mandates, and we will see that what we are discussing today will be a thing of past.
Thank you so much.
Thank you.